The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome. Thank you for joining us for today's program on Health Information Exchange Leadership, spotlighting the work of Group Health. This is Kate Berry, CEO of National eHealth Collaborative, or NEHIC. NEHIC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care. We work very closely with the Office of the National Coordinator for Health IT, and NEHIC's three major areas of focus include health information exchange, consumer engagement, and education. Today we are very pleased to welcome Dr. Gwendolyn O'Keefe, Chief Medical Informatics Officer at Group Health, to discuss Group Health's HIE strategy. I'll introduce Dr. O'Keefe in just a few moments. Next slide, please. First, I'd like to make some brief opening remarks. I'm excited to announce that NEHIC is launching a new membership program. We invite all interested stakeholders to join this new program. The benefits are highlighted on this slide and include visibility and recognition for being part of an influential health IT organization, preferential participation in strategic work groups and collaborative discussions on health IT issues, member-only opportunities for networking with health IT thought leaders, discounted participation in our conferences and education programs, a weekly summary of health IT media stories and synthesis of critical information. So for more details, please visit the URL at the bottom of the screen. Next slide, please. This slide just highlights some of our very first organizations who joined the NEHIC membership program already. As you can see, we've got a number of industry leaders on board. We're very grateful for their leadership and their support, and we encourage you to join as well. For those who become NEHIC members within the next month, you'll be invited to an exclusive member-only event in late July with a very highly regarded and prominent leader, former Secretary of HHS and former Governor of Utah, current head of Mitt Romney's healthcare team, Mike Levitt. Next slide, please. Now I'd like to just briefly highlight our upcoming NEHIC University programs. We've got an advisory council who helps shape the curriculum, serve as faculty, help to recruit faculty, and provide additional advice to us. Our council has representation from almost every segment of the healthcare industry, and we're really pleased to have them as part of NEHIC's extended team. Next slide. As you know, we offer a wide variety of education programs through our NEHIC University, and this slide just highlights a number of the major topic areas. Next slide. We have several programs coming up in the next several weeks. On June 25th, the Council for Affordable Quality Healthcare, or CAQH, will discuss the federally mandated operating rules and the implications for reducing costs of exchanging administrative information and aligning with the Nationwide Health Information Network initiatives. For this program, we'll be joined by Ross Lippincott from United Health Group, as well as Gwen Lose from CAQH. On July 11th, NEHIC will kick off a new series on careers in health IT. This first program in the series will include an overview from ONC about their workforce development programs, as well as a speaker from Texas State University to discuss their innovative workforce development initiatives. Next slide, please. On July 12th, there is a very special live webcast event that NEHIC is convening with ONC, and this will be a discussion of a collaborative project among ONC's Beacon communities and several EHR vendors to accelerate interoperability and health information exchange. This program will celebrate the 2-year anniversary of the Beacon program. And then on August 7th, we'll have a case study of Aetna's accountable care and consumer engagement strategies, including how they're using the iTriage tool to engage with their beneficiaries. Next slide, please. On July 16th, NEHIC will be convening our Consumer Consortium on eHealth here in DC. And for all of those of you with an interest in consumer engagement in health IT, you should plan to join this meeting, but do sign up very soon as there's limited capacity. The importance of consumer engagement in health IT is really heating up, particularly in light of new payment and delivery models such as accountable care and patient-centered medical homes. The agenda for the July 16 meeting will include updates from ONC and many others who are making progress with consumer engagement programs, examples of innovative patient engagement tools and solutions, panel discussions of examples of how organizations are succeeding with grassroots consumer engagement programs, and a working session on health IT messaging targeted to consumers, a patient engagement framework that has been developed, and patient engagement best practices, including brainstorming how these tools can be used by participants. Next slide, please. You can download and print the slides from today's program through the NEHIC store. And starting on July 2nd, we will have a modest charge for non-members to access the slides and other presentation materials. NEHIC members will have access to the slides and all other presentation materials as a benefit of their membership with NEHIC. Next slide, please. During the program, please do enter your questions as they come to mind by typing them into the Q&A window at the bottom right side of your screen. And now I am very pleased to introduce today's speaker, Dr. Gwendolyn O'Keefe. Dr. O'Keefe has been with Group Health in Seattle since 2009 and has been CMIO for the past 2 years. She leads the informatics physician group as well as the care delivery IT teams. Dr. O'Keefe is a general internist practicing in one of Group Health's Seattle-based clinics. Prior to joining Group Health, Dr. O'Keefe was medical director for general internal medicine and assistant professor at the Medical College of Wisconsin, where she was a physician champion for the EMR implementation. Her previous industry roles include leading a medical and drug safety program at Medco Health Solutions, a leading pharmacy benefit manager, and a similar role as medical director at Active Health Management, now owned by Aetna, in New York City. So now I will hand the program over to Dr. O'Keefe, and after her presentation, we will open it up for Q&A. So once again, as a reminder, please enter your questions as they come to mind. Dr. O'Keefe?
Thanks, Kate. That was a great introduction. I appreciate it. Thanks, everybody, for joining us this morning. I'm really pleased to have the opportunity to tell you about our approach to health information exchange at Group Health. Next slide. So Kate asked me to give you basically an overview and case study of how we approach HIE at Group Health. We take a very pragmatic approach, and so I'm going to go today through an overview of a little bit about Group Health and who we are, because that actually sets the context for how we have approached HIE. We're going to tell you a little bit about the past state of information exchange at Group Health, because we have had a significant amount of that over the past 10 years. Then I'll tell you about the development of our HIE strategy and how we've approached new efforts in HIE and some of the challenges and lessons learned along the way. And then we'll have plenty of time for questions and answers. Next slide. So Group Health is based in Washington State. We use our clinical vision to drive how we implement technology solutions. We are the largest statewide group practice. At this point, we have over 660,000 members that are served by Group Health physicians, which has over 1,280 providers in primary care and a number of different specialties. You can see from the map here, our clinical locations are grouped around the Seattle and Puget Sound area and in eastern Washington on the eastern side of the Cascade Mountains. We have 25 primary care sites, 4 large multi-specialty sites, and about 10,000 employees serving the delivery system. The other half of our business is the payer side, and we started about 60 years ago as a cooperative. We still are a cooperative, and we have integrated payment and delivery, but we are also now serving more traditional insurance markets with what we call choice products. And so that has led us to contract with over 9,000 physicians in our contracted network and 44 hospitals across the state. On the map, you can see the shaded area is our overall service area for our insurance side. And our members are mobile, and they move across the state, and that has, for a long time, led us to need to exchange information across various locations. In 2002, we implemented the Epic as our electronic medical record, and we actually started in an opposite fashion to what most delivery systems do. We implemented it with the patient portal first. So we populated lab, radiology, pharmacy information, and also opened up the ability to secure message one's care teams at the same time. That was before we actually started clinician documentation and order entry, which started very soon after that. But as of today, about almost 70% of our group practice patients are using our patient portal to actively manage their care and interact with their care teams. Next slide. Sorry, I'm trying to hit the advanced slide on my keyboard. That's not working. So our vision for the future of healthcare is that we will have seamlessly integrated information systems connecting our patients no matter where they are, whether they're in our delivery system, whether they are at one of our contracted providers or outside hospitals, and that this will include information around their problems, labs, images, medications, referral reports, everything that's needed to care for patients. Next slide, please. I want to tell you a little bit about our history. So we have taken an opportunistic approach over the past 10 years. We have a number of hospital partners. We do not actually own our own hospitals anymore. And we partner with several large facilities here in the Seattle area and then others around the state. And we have had, over the years, have accumulated a lot of point-to-point interfaces. A lot of them have included, with various institutions, transcription interfaces, which has provided a very rich source of information, albeit in a free text form. But we have built a lot of care processes around the fact that we get these transcription interfaces from our largest hospitals. As you can see here, we also have lab interfaces with a number of hospitals. INHS is a very major partner of ours in the Eastern Washington region. But one of the things that's been specific to group health is that our interfaces have been unidirectional. We receive data, but we have not been so great about sending data back. And that, I think, has been a factor of our previously closed system and the fact that most of our members get their primary care in our system, although they may get specialty care outside at times. And we've wanted to, as much as possible, develop a centralized, complete patient record within our own system. So these lab results in structured format, the dictation and transcription notes and other forms of information are sent into our Epic EMR. Next slide, please. The other piece that we focused on building connections in a variety of ways has been for radiology images. One of Group Health's focuses is on managing overall the total cost of care and having very efficient care processes. So it's been very important to us to make images available to all of the providers, whether they're in the group practice or they're in our contracted network. One of the intricacies of our organization, which I think is evolving in healthcare right now, is because we are both a payer and provider, and Medicare has a lot of strict requirements for Medicare Advantage organizations, of which we are one. We, I think, much earlier than standalone delivery systems have had to pay a lot of attention to encryption requirements, privacy and security requirements that may go beyond what the regular delivery system may be doing at currently. So we've had a lot of problems with this, to be honest. We have had to, if we are sending studies to patients, we send them encrypted, to providers. We can only send unencrypted studies directly to patients. So we've gone to great lengths to build point-to-point connections with our biggest partners, but they do have some limitations in what we can do with them, and it is costly to build these individual connections. So next slide, please. So a couple of years ago, we determined we really needed a better strategy, and as you all know, health information exchange approaches have been evolving. The federal government has been putting a lot of funding into health information exchange. And we determined that we were going to take a different approach. Next slide. So the organization agreed that we need a proactive approach rather than our reactive approach that we've had in the past. We need to be strategic about what our goals are, both for patient care and our other organizational goals. But we also have to have an economically feasible program around health information exchange. And it has become quite obvious. We do have a lot of resources, but we don't have unlimited resources. And building point-to-point interfaces is not a viable long-term economic strategy for group health, or for any organization probably. But we have had rich data from these point-to-point interfaces, and that has created a little bit of a challenge for us in moving forward with HIE in terms of getting buy-in, because we have to be clear that we are optimizing patient care as the primary goal, but we don't want to move backwards from what we're getting with our current point-to-point interfaces, which is definitely richer than what you can get from what many HIEs are currently providing. Our other goals need to be around improving our business processes and lowering costs, and using standard tools available. And we do want to encourage the development of open source standards and low-cost solutions so that all providers can participate. We are a very large integrated delivery system, but we also recognize that even the 1 to 2 doc practice needs to be able to participate in health information exchange if we're going to take the care of patients that we need to. The other standard across group health, because we have had an EMR for so long and our providers are used to accessing basically everything through one electronic record, is that we need to continue for our health information exchange to have one method of access for all of our providers. I think that we've had a very fortunate situation here. The Pacific Northwest has a pretty high penetration of health IT. And because group health had made such an investment in this and viewed it as, from early on, as a core piece of how to provide patient care, we invested a lot in integrating our own lab and pharmacy and radiology systems, et cetera, into Epic, so that our providers really do have one-stop shopping and do not need to go to other portals. We also have connections to our other contracted hospitals. So it's really been extremely easy for our providers, and I think a very different experience in a lot of ways from folks in other areas or other institutions that haven't been able to do that, which is more typical in the United States. So my role, I have to emphasize what we are getting from moving to these new solutions and be careful that we don't take a step backwards in our ability to provide streamlined patient care. Next slide, please. So we've identified, this is a standard HIE maturity model, and we, in talking about this with our executives, we've had to educate them on where are we in the current state. So you may have seen this before. The 0 level is in the paper mode. So pretty old school, but that is actually how most of healthcare is conducted. The fax and printer communications are level 1. We certainly still do quite a bit of that actually at group health. And people are very, very used to that. And then, as I said, we have many, many point-to-point interfaces. We have a very large interface engine team here. And I would say we probably have on our IT team at least 16 people who are totally devoted to our interfaces and to our interface engine. Data aggregation, we do population management, we do quality reporting measures. We are in the process of advancing our data warehouse. And as you can see with the blue arrows and the orange arrows, we have other solutions that are fitting into the pull and push methodology. But we haven't reached the full interoperability stage yet, which is where we ideally want to go. And I'll bet that a lot of organizations are in this same realm of having a variety of different stages of maturity. But our goal is to move away from the fax and printer and point-to-point interface and move everything up to pull and push and interoperability levels of maturity. Next slide, please. So I'm going to talk about our 3 approaches that we've been taking. And number 1 is, one of our core principles is to utilize what we have, do more with the software we have, and to be very pragmatic. The key is to be taking care of patients. And so along those lines, we have implemented the Epic-based Care Everywhere and Care Elsewhere tools. In our current state, we're on Epic 2009. So what we are using right now is a view methodology. So this is a view of what we call chart review, but does give us many of the same capabilities that we have now with our transcription interfaces, which is the ability to see notes and documentation at other institutions once a connection has been made. And this, as we're using it right now, this is a pull connection for us, although we are investigating some other capabilities here. The other unusual thing that we have here in the Seattle area and what we call the I-5 corridor, Interstate 5 goes up and down the entire length of Washington and into Oregon, and I guess into California. So many of the large systems here are either on Epic or will be on Epic by the end of 2013. There's a number of installations happening right now. And by the end of 2013, actually, all of our large partners, save for one hospital, will actually be on Epic, which is highly unusual, I guess, in some states, but more and more places are seeing that predominance of one vendor. So we have taken advantage of that. Although our goal is to be able to communicate with anyone regardless, it has to be EMR agnostic. That is our ultimate goal, but we recognize that in the principle of taking excellent care of patients, we needed to use the tools available to us. So they have a couple of different authorization flows, and I will talk more about this a little bit in under challenges. We have started with point-of-care authorization, authorization for the future, or otherwise known as prospective authorization, is something that we're starting to take advantage of. And building out the ability to share CCDs with non-Epic clients is another capability that we are building out right now with Epic. Next slide, please. So our second approach is through the Washington State HIE. And this is administered by a company called One HealthPort. So One HealthPort is the designated agency to develop Washington's statewide HIE approach and implementation. We as Group Health are on the HIE leadership team. I think that One HealthPort has done a fabulous job of moving this HIE approach forward in Washington State. I think we've been identified by ONC as one of 5 states that they're really watching because they think we have a very viable model. So I'll tell you a little bit about the approach that was taken and how we're participating, because we are very, very committed to making this a success. As both a payer and provider, we have a very compelling business case to support HIE. We totally recognize that this can be difficult for fee-for-service organizations to have that business case. So we've been very participatory in this as a payer to try to support organizations using this and encourage adoption, and as a provider because we want to improve patient care. So the way One Healthport went about this was they gathered together stakeholders from all areas of healthcare in Washington, and this happened a couple of years ago. There were a couple of large public sessions in various parts of the state that had a wide audience from providers, from payers, public health, labs, blood banks, all kinds of healthcare organizations. And anyone could participate, and there was lots of discussion and debate, but it was focused around what were the types of data that organizations would feel that they would utilize and would actually be willing to pay for. And I actually think it was a great way that we went about voting on this, because each organization was given a certain amount of monopoly money during these sessions. And after, in a couple of sessions, we generated lists of the different types of data, and then there were voting sessions where you voted with your monopoly money. And the data sets that got the most monopoly money won out as being the first to prioritize. So I think it was a very open process, very egalitarian, and that's led to higher engagement, I think, than we hoped for, which is great. So the initial data sets that were selected were to set up the exchange for continuity of care documents, eligibility data, ADT data, and lab data. E-prescribing actually came along a little bit later as part of some government requirements and other aspects. But those four, CCD, eligibility, ADT, and lab, were the first four pieces of information prioritized by the group. Next slide. So over a series of multiple sessions and design sessions, strategic planning, et cetera, the HIE leadership group, which was composed of leaders from many large healthcare organizations, the 3 largest payers in Washington State participated, of which we are one, but we were participating in this both as a payer and provider, large hospitals, some regional RIOs participated, as well as some labs and others, and determined that what was going to be the best business model and to meet the initial use cases was going to be a hub model of making data available to pull down to your individual institution. As you can imagine, there was a lot of debate about repositories, and the group voted and was very clear that we did not feel there was a business case for a repository at this time. And actually, even a master patient index at this point has not been determined to be something that will stand up to our business case. And we can talk more about that in Q&A. I can answer questions if people have. So there has been a great initiative on various organizations in the state to sign contracts and sign up with the HIE. Many organizations are working through testing right now and initial adoption. Some examples of organizations that are participating that are important to us are Medicaid, some safety net clinic organizations, the statewide safety net group. Some of our hospital partnerships have signed up, and we're currently testing to be able to start to exchange some things with them that we've previously done with point-to-point interfaces. And also a number of rural organizations have signed up, and that was the other key component that our state wanted to support, because Washington has urban areas here on the coast, but also has a great deal of rural area and a large network of small clinics and small rural hospitals. And it was very important that this be financially viable for all. And we can go into, if people have questions about the pricing structure and all that, we can talk about that as well. So for us at Group Health, we expect that we will have a three-pronged approach. I'll go into the third in a minute. but that this will be, to our clinicians' perspective, that this will be behind the scenes. They won't be able to tell when they're using the Epic interface versus accessing One Health port or accessing the national network. That was a key goal, was to make it easy and seamless for clinicians and care providers. Next slide, please. So the third effort that we're engaged in is on a national level, and this is through the Care Connectivity Consortium. We are one of the 5 current members: Kaiser, Geisinger, Mayo Clinic, and Intermountain Healthcare. The goal of the consortium is to lead the nation in developing effective exchange of electronic patient information to enhance care coordination for our patients. We've been focusing on initial clinical data set, authorization, and operational workflows for exchange of these this clinical data set, and on using open standards and an easy onboarding process for new members, because again, we want to enable all providers to be able to use this kind of health information exchange. The reason that we're engaging in this, because you may say, well, you're just a Washington organization, why would you care? But we recognize that our patients travel. We actually have a reciprocity agreement with Kaiser specifically on the West Coast and Hawaii. And so we actually have a driving reason for improving the care of our patients to participate in this. And also because we are so focused on smooth care coordination, no matter where the patient is cared for, this was the right thing to do from our perspective. So the the first instantiation of the CCC is up and operational, and we have had some exchanges through it. And we have actually seen patients through a variety of our systems have connected through HIE from as far away as over 2,500 miles, both to the west of us and to the east of us. Next slide. And you can see this is the presence of the Care Connectivity Consortium founding members. And I'm sure you will be hearing a lot more about this as we move forward in building out the business model and the operating agreements and structures. Next slide. So to recap our approach at Group Health. So utilize the tools you have. Utilize our Epic tools. Maximize the use of the features there. Participate and fully support the Washington State HIE. Again, as both a provider and a payer, we have a very compelling case and participated in the initial setup of this so that it can be accessible to everyone. And then encourage the development of the nationwide health information exchange through the Care Connectivity Consortium, and enable the national exchange through an open source and standards-driven platform as much as possible. Next slide. So we've had some struggles. I think this is definitely something that every organization has different perspectives on it about how to approach. When we started out with, actually it was with Care Everywhere, we actually started with a very restrictive privacy policy. Group Health had that approach overall. And what was interesting, even though Washington is an opt-out state, our organization, as did every other organization around Washington when we originally started using Care Everywhere, initially required consent from the patient at every release. And that stayed in place for about 6 months of initial operation, and quickly became to be realized that this was very onerous and actually makes it very difficult to effectively use HIE at the point of care. So we've grown in our approach to this. Our organization overall is taking a much more risk-based approach. We've greatly expanded our consent, what our consent will cover. We are, some organizations have incorporated consent for HIE into their notice of privacy practices. We still have a separate agreement for that, but we are becoming more comfortable with this, every month. The other thing that I actually found surprising as a clinician was the change management required in the practice. It was definitely much harder than expected to get clinicians to adopt this. I actually was surprised that I actually have had clinicians say to me, I know that X, Y, and Z hospital will fax me the records if I need them. My medical assistant's great at tracking all that stuff down. Why do I need to figure out how to do something new? And I really attribute a lot of this to the difficulty we all have with accepting change and making a change in how we do things on a day-to-day basis. Because once people have adopted this, we've seen the use of it grow in specific clinical sites. It's getting over that hump and teaching people how to do something. Even though it's very easy, it is just different. So that's been surprising to me. We're actually putting much more effort over the next few months into a roadshow to train people and encourage adoption and have champions for this out in each local clinic site as much as we can. So that's been a surprise to me, actually. And I also attribute some of that to the fact that at Group Health we have had this record that has a massive amount of information, and I think our clinicians sometimes have a little bit of a different experience than I've experienced, certainly in practice at other places. The last thing was not a surprise, but we knew that we really needed to ramp up for technical skills, and there was just a huge learning curve. Participating in the CCC has been a tremendous source of learning for our technical folks, and just learning overall along in partnership with the state HIE team has also been a great experience. But the key thing to having HIE be successful is going to make it so that the individual clinician doesn't need to have any technical skills, and that these things will work seamlessly in the future. And we feel like we're really contributing to all of that troubleshooting that needs to happen before this really is successfully quite widespread. Next slide. So with that, I am ready to take questions.
Thank you, Gwen. This was a fantastic, fantastic presentation. We do have some questions that are coming in. I'm going to throw you a softball first. Someone sort of asked a clarifying question. Who do you refer to as your members? Is that your patients? And maybe you could just touch on that.
Oh,
first.
yeah. Sure. Yeah, that is easy. Thank you. So our members are those who have group health coverage or insurance coverage. Patients are those who are seen in our group health facilities. So you can be a patient and a member, and the majority of our folks are both patients and members. But we do have some members who live in very rural parts of the state where we do not have clinical locations.
And we had another question. You've talked about how you implemented Epic, and although sort of also commented vendor agnostic. So that we had a question: Are there any alternatives to Epic, such as Allscripts or others, within the specialty community or contracted network that as you expand, your network?
So let me take a crack at what I think the question is asking. So certainly there are plenty of alternative electronic medical records, and the key is that your electronic medical record has the ability to generate a CCD document and other pieces of discrete data to be sent, to be able to be transmitted through a health information exchange. And that is part of the meaningful use requirements. So Allscripts, Cerner, those many, NextGen actually is the system that's used by a lot of our safety net clinics here. That's part of their certification requirements in order to be able to qualify to be an EHR that's used by a provider who wants to achieve meaningful use. So there are definitely plenty of alternatives. The key thing is to make sure that they are certified EMRs.
And if you in your community have physicians that maybe need to exchange that may be using different systems like that, I mean, do they exchange the CCD through one health port, or do they have another point-to-point, or how does that work?
So the majority of folks are going to be exchanging through One Health Port, but they may also, and I can't speak to other EMRs, I don't have that much experience with them, but the larger ones will also have the capability to accept a CCD into their system. And I know some systems are still working on developing that, but the CCD is something that will any provider through any vendor package that they have that can generate it can exchange that through One Health Port. And for us, simply the way we would visualize that and see it from a clinical perspective would be through the Epic, what we use, the Epic Care Everywhere space, basically in Epic, but it's actually being passed through One Health Port. The other thing that the ONC has established also for passing information is through the direct protocol, and we have not started using that yet, but I would like to see us do that, and that is something that clinicians, smaller practices could use now. It's basically secure email, and there are practices that are working on that.
And you had mentioned also, Gwen, that you have that you've done a lot of point-to-point. I mean, would direct sort of be an alternative to some of the more costly point-to-point interfaces, so that would sort of just enable that direct, secure exchange?
Well, for what we've done, so most of our point-to-points are lab interfaces, and direct won't really serve for that for us because we're actually taking in structured lab data that way, and direct is more free-form. And so, but our goal is to eliminate all of our point-to-point lab interfaces as organizations around here get up on the One Health Port HIE, because lab is one of the first things that we'll all be doing. So we are hoping to go to a more economical support model by eliminating those over the next couple of years.
That is something we hear a lot of challenges around. So we have another question for you about kind of the, you referred to, the group health really does have a very powerful, compelling business case for HIE because being a provider and a payer. Could you just elaborate on that a little bit more in terms of, how what that means and how you measure your ROI given that integrated model?
Sure. So so we measure our success around the total cost of caring for patients. So, and what we call the per member per month or per member per year cost. And everything that is sort of done to or happens to a patient in healthcare contributes to that. And that is the cost that we bear as the payer. So every single CAT scan, every MRI, every doctor visit, every lab test will accumulate to that total per member per year cost. So any solution that we have that contributes to reducing duplicative care and improving communication allows us to reduce that cost. Now, I will say we have not yet, but this is something I think we'll be able to do in the future, be able to do, we could probably do some pre-post studies. We'd have to think a little bit harder. There is an element of belief that this will simplify care and reduce duplication. There's also evidence out there that shows that this is the case, that an HIE in place will reduce duplicative use of resources. So that's our goal as a payer. Our medical group and our group practice is aligned around that. We are a very similar to a staff model group practice, and we're aligned around caring for patients in the best quality of care, but with a controlling cost of care as well. And but the average, just the unfortunate fact of the way the American medical system is set up right now, and that's why there's so much discussion about moving to accountable care organizations, is that the current way that most medical reimbursement is done is around a pay for service, whether it's a visit or a study. And so the incentive is not there, for instance, for a hospital with a large radiology center to want to do anything that could reduce the use of their radiology center, for instance. So we recognize that we have a more powerful incentive structure there. As far as truly measuring the ROI, right now we don't have great measurements around that. But we do a lot of measurement around our total cost of care, and where we have better information and more integrated care, we definitely have a lower cost of care.
And I suppose it may be hard to isolate, one specific use of technology from other clinical processes, et cetera. But I mean, so that's great. It is an interesting, you've basically already, transitioned from fee for service to patient-based or population-based fees.
Mm-hmm.
You mentioned at the beginning that you sort of implemented, the patient portal first, which is sort of unusual. Could you talk a little bit about? And then I can't remember the statistic you said, but something like 90% of your people use the portal. So how did you get people to use it, and what do they mostly use it for?
Okay. Yeah, so so our big belief is that the more information patients have, the more engaged in their care they will be, and the better quality of care they'll get. So it is about 70% of our members who are using the portal. So we've gone through a couple different things to really get people engaged in using it. So just making it available to people and having physicians interacting through secure messaging got us through sort of a first wave. We did early on do some incentive programs for physicians to participate in it, very nominal things for participating in the secure messaging. Now, as part of, and I didn't talk about this, but our medical home setup and how we provide specialty of care as well, using secure messaging is a basic expectation. And so if you're going to come work at group health, this is just a basic expectation, and there are no longer any kinds of physician incentive programs. But patients are more likely to use it if their physician actually answers their question. The other thing, though, that patients, the things that are most utilized on it are viewing lab results, scheduling appointments now that we have direct scheduling, and also checking for pediatric patients, getting the repeat printing of immunization records is very helpful. And then lastly, after visit summaries are a standard of our practice, and patients can view those online as well. And we have both, almost all lab results are released immediately. That's taken some evolution over time. And we also now release all radiology results, MRIs, CAT scans, X-rays, with some delay to the timing of it. But that's all available. There are other functions that you can do on there, but I think viewing results is by far the most popular, and then scheduling appointments, and then third is the email. We did have, when we implemented our medical home a couple of years ago, we had a big push then as well to help people get signed up. There's a two-step authentication process, which can be a little bit onerous, and you would definitely see a drop-off between the first and second steps of people who went through with it. So we had very active marketing of it and made it so you could do that whole process right in the clinic, and that helped quite a bit as well.
So Gwen, we have several questions. You talked a little bit about your managing patient consent. We have some questions around privacy and patient consent. So if you could elaborate a little on that, and including one question, what does it mean that Washington is an opt-out state? So how are you managing kind of what your privacy policy, and then how you manage patient consent? What do they consent to? How do they consent to it? What do you explain to them, et cetera?
Right. Okay. So first of all, let me just say, so an opt-out state means that patients would need to take an action to opt out of their information being exchanged for healthcare reasons, as a simplistic explanation. And I am not a privacy expert, so I'm going to do my best at this. So The other states have opt-in policies where a patient has to sign a consent before you can exchange any information, and so that's one of the challenges, is that all 50 states have different iterations of how they implement privacy regulation, or what they determine are their privacy standards. So at our institution, and I don't remember the explanation on the consent to go through the electronic HIE, but it is basically a simple, and we run a lot of our communications like this through what we call a plain language committee, so it's written at a 6th grade level and in clear language for patients. But basically explaining that if you consent to this, we will be exchanging electronic copies of your healthcare information for purposes of treatment. And it used to be, when we first started out with that, very limited. It was very specific that it was just for that particular point in time. We retain all of those copies. That's one of the things the software gives us the ability to do, is allow the recording of who got the consent, what, timestamp it, so you have a very strict audit trail, and a scanned document repository for all of those consents. So that's how we manage that. I really would like to see it move to the overall notice of privacy practices, because, in the regular practice of medicine, the healthcare organizations are actually fairly variable in terms of, for instance, if you went to the ER and you come in for a clinic visit and your clinician calls the emergency room and gets the ER discharge summary, it's highly variable as to whether people do get consents for that or not. So basically, patients are, in the way we administer this now, patients are asked for their consent the first time that we implement one of our HIE queries. And now, currently that consent here at Group Health is good for 90 days. We'll be expanding that soon to be good for a year. And we track it, have audit trails, and retain all those signed consents. I hope that was what
great.
people were looking for.
It's one of those that this is one that, it's awfully complicated and lots of folks struggle. So we have a question for you. Can you speak to any information exchange activities being initiated in your community with VA facilities or local military hospitals?
Yes. So, yeah, we have in the Tacoma region, in the South Puget Sound area, there's Madigan Army Hospital and the VA there. So there are, we don't overlap much at all, so we have not actually directly connected with them yet, but that is something we'd very much like to do. But other organizations, the large care provider in the Tacoma region does have a HIE using the national standards set up with the VA down there. I can't speak any more detail than that, but yes, that is definitely a part of what's happening in Washington.
Very good. And we had a question about the budget. Can you say what the annual budget for One Healthport is?
So what I can say for us is the way I think our total fee is going to be $50,000 for next year, and just consider the size. That is the largest organization fee. The average small or a one-doc practice would be, I think, $300 or $600 per year, and there are not transaction fees. And part of the incentive money that went to set up the state HIE is being used to subsidize small practices signing up, and basically actually practices of most sizes being subsidized to do the initial licensing.
So the revenue model for One Healthport is that the connected participants pay fees, annual fees, subscription type fees, as opposed to transaction. Yep.
Yes, yeah, and we had a lot of debate around that, and so we came up with, there were a couple iterations of, so how do we break up the various sizes, and there's different ways to qualify depending on whether you're a payer or a practice or another kind of institution like a public health agency. But the key key goal around this was to create something that would be financially self-sustaining within a 3-year period of time. And they're very confident that we're actually going to achieve that.
And they were one that was here before the federal HIE program, so presumably they'll be here after. I mean, it sounds like you've got a model that's likely to continue, which is great.
Right.
We have a couple questions, and this will probably have to be the last one given the time, but you know, you commented on provider adoption being a pretty big challenge, and we sort of have the question, in getting clinicians to adopt the workflow change, how did Group Health come up with the idea for training roadshows and clinic champions? Were there other strategies that you've also tried with regard to adoption?
So we came up with that strategy because we've used it for other things. That's one of the benefits of being in a large integrated delivery network, is you have a little bit more resources for that kind of training. And we found that you have to go, what seems to work the best is to go and meet people where they are and really show them the practical aspects of it. We've had we've had collateral that's gone to, like marketing collateral, essentially, that's gone to patients and been out in the clinic. We had initial training sessions. We have some e-based electronic training that's available, and we publish newsletters with links to those trainings, and we're trying every way we can to communicate with people and give them the links to the information that they need. And part of it has been interesting. It's also just about workflow in the clinic and how it really shouldn't have to be, in my perspective, it shouldn't actually have to be something that the clinician has to do themselves, because the most efficient thing is to have it get established before the clinician is seeing the patient. But that requires communication amongst the healthcare team and recognition that the clinician thinks this is important, because otherwise other staff are not going to undertake a task that they don't have the view that the clinician thinks is important.
Great. I'm going to actually give you one more since we have another big question in here. So how do you manage the terminologies from all your different data sources? Do you cross-reference or map them with standards such as LOINC, SNOMED, et cetera? How did you do that translation of the terminologies?
Yeah, so for lab, for our lab, and actually the other couple of big labs that we deal with use LOINC. With ICD-9, we do not map to SNOMED right now, but ICD-9 codes, CPT codes, those are all pretty standard. We use HL, HL7 can be fraught with challenges, but yeah, for anything where we're looking for standard data, we're using the standard terminologies. We will be moving probably to. We still have to figure out, about RX norm. We don't use that right now for medications, but we also do not incorporate right now medications in a standardized format from outside institutions. The CCD standard is we're using the standard for CCDs. Now, in our data warehouse, there is mapping that's going on between different systems for what we're populating into the data warehouse as well.
Very good. Well, we're going to have to let that be the last word. So, Gwen, thank you so much for a fantastic presentation, and thanks everyone for joining us. I think we had a really interesting and thought-provoking Q&A, so thank you for that. We're going to just pop up a quick survey on the right side of your screen. So before you sign out, please just take a quick moment and complete our survey. We really do need your feedback. And we hope you'll join us next Monday for the CAQH program on the role of mandated operating rules to simplify healthcare administrative transactions. So, Gwen, thank you so much again, and I hope everyone enjoys the rest of the day. Thank you.
Thank you.